So, yeah, so what was your thoughts? I'm just curious as to how I am being perceived and how people are perceiving my whole purpose and my whole, what was your thoughts as you were seeing my posts?
When I saw your post and, the training platform, the way I looked at it is, okay, here is someone that wants to kind of open the floodgates for nurses to not just be your, I'm going to call it stereotypical bedside patient care, nurse, but also understand that there are different multiple avenues that you can get into, right? And that nursing is actually more of a qualification, right? Where you have the versatile skill set to be able to do a plethora of things and not feel feel limited that, oh, patient care is all that I can do as a nurse. So that's how I took it. And so what I really liked about some of the messaging that you were sending is it's pretty much those nurses that have been maybe afraid to venture out, because in my career I have encountered bedside nurses that are like, let me take your phone number down, and if I want to do something, can I call you? And I was like, yeah, of course. And so that's what I noticed and loved. The other thing is mentorship really stood out to me, because one of the things that I've noticed in my 11 plus years as a nurse is mentorship is almost non-existent, I feel like, between nurses. And if it is, it's very like guarded, and it's not as available. So if someone wants to become a chief nursing officer one day, what is the path that you're going to take? And also, there's not just chief nursing officers in the hospitals. There are chief nursing officers for, kind of education institutions, value-based care companies. What does that look like? How did you get to where you are so that you can kind of share that knowledge and not knowledge hoard? So anywho, that was kind of, it
I
was,
love,
yeah,
we are going to partner in more ways than
yeah,
one, because
yeah.
I think you understand, you obviously, have gone on for advanced degrees.
Mhm.
I I think that's wonderful, and I think
Yeah.
I admire people that that can do that. For me, I wasn't able to do that because I got married young and had 4 children, but
It's
I've
never
all
too late.
it's
So,
never I know that too, but I'm doing something
mhm,
like that I feel is purposeful and valuable to nursing. And I think
mhm.
that at the end of the day, that's the most important to me, is what am I going to leave as my, I may not have gone up the education chain or the leadership chain, but maybe I can make a difference in other nurses and make a difference in patients' lives,
Mhm.
by doing what we do. And so I'm really, really excited to hear,
Yeah.
about utilization review. I've done a little bit of utilization review, and I did some HEDIS review work,
Mhm.
and just as on my journey. And I always tell people my story is that along the way through those 4 kids, I would pivot my career or my
Mhm.
job to meet the needs of what was going on in my family at that time, because my husband is a firefighter and did shift work.
Mhm.
So, what it did for me, first of all, it got me out of my comfort zone, because when I was younger, I did not like change.
Yep.
But this forced me to like say, okay, I can do this. And
Mhm.
long before there I understood what it meant by translatable skills, I
Mhm.
was doing it, but I didn't realize it. And so
Right.
I think that was like something that resonated in my mind, was there's so many nurses that could use my
Yep.
experiences in pivoting and finding roles that maybe, like, I mean, I just jumped in and learned and
Mhm.
studied and found mentors throughout
Yep.
my career, whether it was my HR manager, if I was
Yep.
going into private, to a private company, or somebody that believed in me. Um, and so I think that is what I'm hearing in you too,
Yep.
that in the message, that I'm going to need a lot of nurses, and especially my instructors as a group,
Mhm.
to spread the word about what we're trying to do on this platform, because I don't think anybody is doing there's a lot of people that are in the realm, either they're nurse coaches,
Right.
That are trying to do career resume writing and, helping career coaching kind of things,
Right.
which I do on the side. Like, a lot of people reach out to me on LinkedIn, and I do connect and talk with them.
Yep.
And that was another reason why I'm like, man,
Make it into business.
I should do this, right? And so I wanted to find a place where we could all and all what was it you said about not nurse monsters? What did you say? Hoarders.
Kind of like information hoarding in a way, right?
Yeah.
It's only I'm going to, cherry pick who I think is going to come up the reins, and I'll just share it with them. And it's like, anytime I reach out to another nurse, I reach out because I'm not somebody that likes to withhold information. I'll just share what I know. That's just my personality. And so I've reached out to many nurses of varying backgrounds, and I found it very difficult to kind of break through and establish kind of that relationship, right? Where you're working together. And I understand life gets in the way. Nurses are very busy, right? They're trying to juggle family, career, hobbies, other things that they may be working on. And so that's just one thing that I've observed. And that too, I guess the part of nursing that I've also found to be a little bit more cutthroat is corporate nursing. So whether it is working for a health insurance company, whether it is you're working for a wellness company, whatever that organization may be, corporate, being a quote unquote corporate nurse executive, I have found that to be very cutthroat.
And so what I want to do
Mm-hmm.
is I want to make this a safe place, this training platform,
Right.
a safe place for the instructors where they can freely share because they want to share. They want to pay it forward. They want to empower nurses to do it too in a safe kind of arena where you're not going to have that. And I think it's really important because after COVID, we lost a lot of nurses to the beds from the bedside, and they actually left healthcare in general, left. Whereas I saw it when I retired and unretired to start Stepping Stone Advocacy Services. The first thing I did was to do advocacy for patients and their family, and I learned how to do that. I learned how to become a professional patient advocate and learned how to pay it forward to other nurses that wanted to learn how to do that too. So I had done that before this. And then the second thing before I leave this earth was that I wanted to give back to nurses and make sure that we're moving forward in a way to help patients navigate through the healthcare system, give them this gift of all our knowledge and use our skills in different ways to still stay connected and engaged in patient care, not bedside, but patient and family care. And that's just one example. Patient advocacy is just one of the roles that are out there. I'm just learning so much through this. And that's why I wanted to talk to you so you could tell me about your story. Tell me,
So I have what I like to consider a non-traditional path in nursing, because my very first job at a nursing school, I was a pediatric primary care nurse. So I was doing a lot of triage day in and day out, having parents put the phone up to their newborns, letting me hear them crying, going, "What does that cry mean?" And it's like, I was like, if we all knew what that cry meant, we would not be here today speaking on the phone. And so going from reassuring new parent concerns, I ventured on to working in long-term pediatric acute care, which love that job. I did that at downtown Baylor in Dallas. But then again, how you mentioned your husband's a firefighter, he does shift work, so you're kind of going with his ebbs and flows. my husband's on the healthcare finance side, and so he was going to pursue his MBA and then go on to find his post MBA job. So I followed him to Chicago, where I, went back in, did primary care pediatric nursing, became a nurse manager for that clinic. We expanded to a second clinic, and so I did some clinical operations. That was my first, dig at true clinical operations. I did that. Then from Chicago, we moved to Kansas City. I came to Kansas City, initially worked for the first 6 months for Quest Diagnostics. They were doing that's when the CMS chronic care management reimbursement was so hot.
Yes.
And so I came in as a supervisor for chronic care management. And 6 months down the line, I was like looking, checking my moral compass going, is this right? And so at that time, I wanted to go back into pediatrics. But then the doors at Children's Mercy over there did not open up, and I ended up at Blue Cross Blue Shield of Kansas City as a manager of utilization management. And so that's where my path began. So I would probably say direct patient care, maybe 4 years direct patient care. The last 6 to 7 years has been in outside of, the bedside. And one of the things I will say, I was not prepared for that role at Blue Cross, because no one tells you about the hard transitions between being at, bedside, where everything is urgent, you prioritize, you work so efficiently and effective, to going to a corporate environment where everything is slow as molasses.
And
so
no one's going to die in that moment. I mean, you know what I'm saying.
True.
That's obviously in this environment in today's world. I mean, yeah. But
it's true. But at the same time, don't you want to be efficient? Don't you want to be proactive? And the answer I found to that is no, we don't. We just want to keep doing what we're doing, but make everyone believe that we're doing something, fantastic. And so I was manager for utilization management, prior authorizations, inpatient concurrent review, which is infamous, right? You go to the hospital, is insurance going to pay for my stay? And then transitioning to post-acute care. And then, of course, post-service claims reviews for medical necessity. So I managed all of that for 2 years. Kind of got tired of it at the time, because I was kind of limited at the time, kind of blocked from going up the ladder at the point. So I said, okay, I'm going to back away from this. And what I ended up doing is there was a newly minted transformation office within the organization. So I joined as a program manager, working on all of population health programs, doing Medicare Advantage insourcing, because it was vended out, bringing that in, creating care management programs. And of course, I did a 3-year implementation on a care management platform. So it brings CM, HEDIS, quality, everything
all
together into one platform. So I did that. And then from there, after a while, the organization started getting a little iffy for me, to where I was not enjoying the organization itself. So I went to another health plan, a federal employee benefit health plan, and I was there for about 6 months. During that time, I had my daughter. And so then, this role that I'm at right now as director of utilization management at Village MD came through. Actually, it was really funny, because I had about 3 director offers at the same time. One was the current health plan, the prior health plan that I said, okay, bye-bye, because, it's too late now. The kind of, how should I say, the sentiment, the emotions just soured, right? And so and then I had Village, and I was like, you know what, Village, because I said, I am so tired of the payer landscape right now. So I said, let me go back, and I've got the best of both worlds right now. We are the primary care provider, and we are the payer. So I get the best of both worlds here.
So is this is this a concierge physician primary care group, or what?
So we are situated in multiple markets, nationally throughout the United States. And so we're very much primary care first, right? And then for a subset of our patients, our patient panel, we do utilization management. So we're doing the prior authorizations, the concurrent review, the post-acute care transitions, doing our own.
You all are doing that all in-house.
Yep. Exactly. So what we do is you assume partial or full risk on behalf of the health plan, have contracts with the health plan where they're like, oh, your own patients, okay, why don't you just do all the utilization management services? Why don't you do all the claims payment and just report the metrics back to us? So that's essentially what I do.
So do you all have case managers with you too?
Yes.
There you go. So that is so cool, because one of the courses that we are going to be offering is workers' comp case management, because that's the kind of case management I did for 20 years. But I know there's a lot of nurses that want to pivot to case management too.
The case management we focus on here, two different kinds. One is transitions of care. Coming out of the hospital, where are you going to go? Mr. Smith, you actually should go to long-term care. Do not go back home with your wife because she said she can't take care of you, right? For example.
Yes,
but
we do. And I do that. That's so funny, because I do that as a patient advocate. That's my role.
So we do that kind. And then we also do high-risk care management. So post-discharge, you're following the patient for 30, 60 days, making sure that they all get in for their transition of care management appointment with the PCP within 3 days, ideally within 7 days. And so we do all of that. So I'm really uniquely poised right now because I was also asked by our chief medical officer to put together what I'm doing right now for utilization management, because we do utilization management / care coordination for that small subset of patients. And so what I did is I recently I revamped, let's say, our home health and skilled nursing facility care management programs for the entire organization using utilization management principles. Because one of the things is, yes, has a very bad rapport. I think you've seen the news lately on United Healthcare. They're blazing on fire right now, right?
Yes.
It's very bad reputation for in general. But the one thing is that I don't think people realize is it's the fundamental of why we became nurses. Right care at the right time, place for the right patient. Is it safe care? And that's the emphasis there. It's not cost management follows along, but it's about providing that high quality care. And so I'm kind of in a interesting position where I direct the team, but I'm also doing program design and clinical program design and implementation. That's a lot of the work that I did when I was in the transformation office. So bringing that back here, it helps keep variety and keeps things interesting for me. And so
that is so cool. And I think I definitely feel this connection, because always seeing a better way to do things and deciding and feeling empowered to go and say, I'm going to go, well, I'm done here. But now let me see this job. If I take this job, I can see where I might be able to go in this direction. And I'm sure you thought that too, right? There's so many things that you could do. And that's what I'm trying to, that's the big point of what I'm trying to educate nurses about.
Because if you look at a lot of your remote care management roles, they're all labeled to have transitions of care. Manager. And so this is exactly what we're talking about. There's one organization right now, an oncology specialized value-based care organization called Time Care. They are hiring certified oncology care managers, as well as transitions of care managers that can come in and essentially help those patients who are essentially the sickest of the sickest. They're going to have multiple readmissions back to the hospital. How do you keep them out, and how do you keep them comfortable, and also talk to them about the good, the bad, the ugly, right? Palliative care, hospice care, is that appropriate? And making those advanced care planning decisions. So.
And it's interesting because I will be bringing a death doula on and to talk about that the transition before the transition. And about how nurses can really play a bigger role in that. And it's part of hospice, not directly, but oftentimes as a patient advocate, I play a lot of that role, because I'm in there called in by the family, and maybe they've been through chemo, and it's back again, yet the family isn't ready to talk about hospice. So it ends up being my role as the patient advocate. And I'd like to see more nurses be empowered to take that role on.
Those care managers that are doing true transitions of care should feel empowered, should feel poised to have those conversations. But one of the things I'm observing in my current workplace, in my practice, is they're too timid, because that's not on us to have the decision, especially if the patients and their family says no. It's not about you pushing it on them. It's about you providing that education, empowering
Yes.
them. So when they are ready to make that
Ready.
decision, it's, oh, that nurse talked to me about this like 5 times. Yes, I thought it was really annoying, but I'm glad they did. And
Yes.
so that's actually one of the things I'm observing. And so I think from what you're stating here, your platform, the stage that you're opening up, it's going to be a lot of overlap, but it's also going to be good overlap. So
Yes, because what I'm saying is, again, they can take those transferable skills and say they become a private death doula, okay?
Mhm.
And they decide, well, they don't really want to do that, but there may be a space within your organization where that translatable skill
Mhm.
can be translated over to becoming a care manager in transitions of care subset, i.e. that part of hospital, where you see the continuity of care.
Yep.
They would be perfect in that role because they are comfortable and educated about doing that. And so that's the kind of things I'm trying to put out there for nurses that get on the platform, is to say, even if you don't want to open your own death doula business, even having and learning and getting coached by somebody on this platform provides you with that education to
And
be
the knowledge.
comfortable. Yeah.
I mean, the
Yeah.
other thing too that I'm noticing is many of the care managers have zero knowledge about managed care in general. They don't understand the process. They don't understand the claims process. So when someone say claim denied, it's, why can't you just go in and authorize something for them right now? That's not the way it works. And so I think just a managed care 101, I think in general would be beneficial. And of course, right now with value-based care being kind of the buzz, right? And
Yeah.
you're seeing more of those organizations creating that education as well, because what I am noticing is a lot of people will use value-based care as a buzzword, really not understand what it means, enter into that type of organization to do an important job, and then feel still, how should I say, act like it's a fee for service world, right, where it's transactional. But that's not what you're doing. You're doing value creation, right?
I
Value
like that
proposition.
value creation.
Yeah.
Yeah.
And so I think those are just the things recently that I've been kind of more sensitive to, just because of what I'm observing at my workplace, going, heck, I need to do managed care. And I've been saying this for the longest time, that the care management team needs managed care 101. But again, there's
Well,
only
you
one
can
of me.
do it.
Yeah.
You can do it.
Yeah.
And a lot of my instructors are outside of their employer doing this.
Yeah.
You
Exactly.
know, which is why it's so cool, because they can take this and it's not biased to one employer. You're not focusing on that,
True.
but you're in that world, right?
Yep.
And
Yes.
so you can have that one-on-one. And I love that. A managed care 101 would be amazing. And with too, I think understanding what goes on.
Yep.
What is that about? It's really kind of like how would
You could break out into 3 chunks: pre-service, so prospective review, then concurrent, and then post-service review. Concurrent review would include inpatient and that transition of care into the
right?
post-acute, and then also include home health and DME. And then you have post-service, which is the services have been rendered, your provider is filing a claim, and here you go. Their health plan is looking at it and denying your claim. Why? And
I think this is important. It's important for me as a patient advocate, even like to understand this. So, and when I'm training patient advocates, this would be a very an excellent course. I think any of us, you can't not understand it. It's not that you can, even though, even as a patient advocate, we're a
Yeah.
concierge service and we're paid by the patient and the client. We still have to work within the framework of their
Yeah.
insurance in order to get them the care, right?
Yeah.
So understanding about how we go about doing that is really, really important. I just love
Yeah.
what you're bringing. I
Yeah.
definitely, we can talk more,
Of course.
about this, but I'm really, really excited. I'm going to, I'm going to stop recording now and then we
Okay.
can talk some more.
Okay.